This audio podcast is brought to you by Sanofi Aventis, The Oncologist, Symptom Management and Supportive Care, Chemotherapy-Related Hospitalization Among Community Cancer Center Patients. Created by Michael J. Hassett from the Center for Outcomes and Policy Research, Dana-Farber Cancer Institute, Boston, Massachusetts, USA. Sowmya R. Rao from Massachusetts General Hospital, Boston, Massachusetts, USA. Susanna Brozovic from North Shore Medical Center, Salem, Massachusetts, USA. James E. Stahl, Massachusetts General Hospital, Boston, Massachusetts, USA. And from Mass General North Shore Cancer Center, Peabody, Massachusetts, USA. Joel H. Schwartz, Betty Maloney, and Joseph O. Jacobson. Keywords: chemotherapy, adverse events, cancer, quality improvement. Abstract. Purpose: to describe the frequency, nature, trends, predictors, and outcomes of chemotherapy-related hospitalizations, CRHs, among a non-selected population of cancer patients treated at a community cancer center, and to explore the feasibility of implementing continuous quality improvement methodologies in routine oncology practice. Methods: we conducted a prospective cohort study of consecutive adult cancer patients who received chemotherapy at a community cancer center January 2003 to December 2006. Demographic, comorbidity, diagnosis, treatment, and laboratory data were collected via medical record abstraction. Hospitalizations were classified as chemotherapy-related or unrelated by a multidisciplinary panel. Patients who experienced CRHs were compared with those who did not. Using a randomly sampled subset of cases and controls, we built a logistic regression model to identify independent predictors of CRH. Results: of 2,068 chemotherapy recipients, 179, 8.7%, experienced 262 CRHs. Most hospitalizations were not chemotherapy-related, 73.7%. The mean monthly rate of CRH was 1.5%. The median length of stay was 5 days. The most common type of CRH was gastrointestinal, 46.1%, followed by infectious, 31.4%, and 0.9% of chemotherapy recipients had a fatal CRH. Significant predictors of CRH included having a comorbidity score of 3 to 4 versus 0 and having a higher creatinine level. Conclusions: although the vast majority of chemotherapy recipients did not experience a CRH, these events were, unfortunately, not without serious consequences. Care should be taken when offering chemotherapy to patients with multiple comorbid conditions. Systematic efforts to monitor toxicity can lead directly to improvements in quality of care. The Oncologist, 2011, 16, 378 to 387. Introduction. Chemotherapy can offer substantial benefit to patients with many types of cancer, but also has the potential to cause significant toxicity. Unlike other medical therapies, the therapeutic index for chemotherapy, the ratio of the effective dose to the toxic dose, is often much lower and the risk for toxicity much higher. Consequently, decision-making for chemotherapy requires careful consideration of and accurate information on both the potential benefits and the potential risks. Reports of clinical trials provide detailed information regarding the benefits of chemotherapy. These benefits appear to be similar regardless of whether patients are treated within or outside a clinical trial setting. 1, 2. However, these same reports provide relatively limited and potentially incomplete data regarding the risks of chemotherapy. 3 to 5. Moreover, although the vast majority of cancer patients are treated in community centers or subspecialty clinics, little is known about the risks of chemotherapy in these settings. There are several reasons to suspect that the risks of chemotherapy administered in routine practice may be different from those observed during a clinical trial. Patients enrolled in clinical trials are clearly different. They tend to be younger, have fewer comorbid health conditions, and are less likely to represent socioeconomically disadvantaged populations. 6 to 16. In addition to selecting patients who tend to be healthier and have more extensive social supports, the more frequent follow-up often required by clinical trials raises the possibility that adverse effects are caught earlier, making serious toxicity less common. A retrospective analysis of claims data supported this hypothesis. 17. Unfortunately, prospectively collected data on chemotherapy-related toxicities experienced outside clinical trials are hard to come by. Drug-related serious adverse effects have been defined as any untoward medical occurrences that are related to drug use and that result in death or significant disability, incapacity, require hospital admission, or prolong an existing hospital stay, or are life-threatening. 18-19. We decided to focus on chemotherapy-related hospitalizations, CRHs, as a surrogate for chemotherapy-related serious adverse effects because they are relatively easy to identify and are meaningful to patients, providers, and payers. Our goals were to describe the frequency, nature, trends, and outcomes of CRHs among a non-selected population of cancer patients treated at a community cancer center, to identify predictors of these events, and to explore the feasibility of implementing continuous quality improvement methodologies in routine oncology practice. Methods. Setting. We conducted a prospective cohort study of consecutive adult cancer patients who received chemotherapy at a community cancer center in northeastern Massachusetts. The North Shore Cancer Center, NSCC, was a freestanding ambulatory cancer facility in Peabody, Massachusetts, located 20 miles north of Boston, now centered in Danvers, Massachusetts, and called the Mass General North Shore Cancer Center. Residents of the surrounding county have a median age of 39.2 years and a median household income of $61,505. U.S. 2007 inflation-adjusted dollars. 83.2% are white, 3.2% are black, 2.9% are Asian, and 9% identify with some other race. 20. The NSCC provides ambulatory cancer services, including chemotherapy and radiation therapy, to a region that encompasses greater than 200,000 adults. During the data collection period, January 1, 2003 to December 31, 2006, approximately 1,200 new cancer cases were evaluated, and 3,000 chemotherapy administrations were delivered by the cancer center each year. The NSCC is affiliated with two local hospitals, Salem Hospital, Salem, Massachusetts, and Union Hospital, Lynn, Massachusetts, that are responsible for the vast majority of hospitalizations experienced by patients treated at the cancer center. Case identification and data collection. As part of an internal quality improvement project, the NSCC initiated a prospective effort to identify and collect data on all chemotherapy-related hospital admissions experienced by its patients. A detailed description of the procedures for this program were described previously. 21. In brief, the clinic relied on multiple overlapping case identification methods to identify admissions. Because all oncology admissions to the regional hospitals are seen by dedicated hematology-oncology subspecialty hospitalists, daily comparison of the patients on these services and the patients receiving chemotherapy at the NSCC identified nearly all admissions. For the rare cases in which patients were admitted to non-regional hospitals, these events were identified by missed clinic or treatment appointments and confirmed by clinic staff through direct contact with patients or families and the outside hospital. For each admission, a standardized data collection form was completed by a nurse using the ambulatory and hospital charts as the primary data sources. Information collected included patient age and sex, cancer type, concurrent comorbid medical conditions, date and cycle number for the most recent chemotherapy treatment, intent of chemotherapy, curative, adjuvant, or palliative, date of hospital admission, reason for admission, length of hospital stay, and outcome of the admission, discharged versus in-hospital death. Comorbid medical conditions were coded according to the method developed by Charlson and colleagues, and included the optional age addition, +1 if 50 to 59, +2 if 60 to 69, +3 if 70 to 79, +4 if 80 to 89, +5 if 90 to 99. 22-23. When patients were admitted to hospitals other than the two mentioned above, records from the admitting hospital and reports from the patients and families were used to help complete the data collection form. A second reviewer confirmed the information entered on the data collection form by comparing it with primary source documents. Each month, a team of medical oncologists, hematology-oncology subspecialty hospitalists, nurse practitioners, nurses, and pharmacists met to review each admission and determine whether or not it should be considered chemotherapy-related. An admission was considered chemotherapy-related if it occurred within 30 days following a chemotherapy administration, and it was judged to be definitely, probably, or possibly a result of chemotherapy medication the patient was receiving. All other admissions were thought to be related to the underlying cancer diagnosis or to a non-cancer diagnosis and were considered unrelated to chemotherapy. If an admission could be attributed to both chemotherapy and cancer, the team chose to be inclusive and considered the admission chemotherapy-related. Participants in the monthly team meetings numbered approximately 6 to 10 and were not blinded to the identities of the patients. Attributions were consensus-based. Derivation and analysis of the primary data set. We used the Cancer Center's pharmacy database to identify the total population of NSCC patients receiving chemotherapy in the ambulatory clinic. Because the pharmacy database records every newly started chemotherapy regimen, it provided a reliable method for determining the size and characteristics of the population of chemotherapy recipients at the NSCC. Pharmacy data were merged with CRH data, information on patients who were hospitalized with chemotherapy-related adverse effects, to create the primary analytic data set. Pairings between the two datasets were based on matches between multiple unique identifiers, including medical record number, patient name, and patient date of birth. We used this merged dataset to characterize CRHs, the patients who experienced these hospitalizations, and the frequencies of these events among all new chemotherapy regimens. Individual patients could experience multiple CRHs and start multiple chemotherapy regimens. These analyses focused on hospitalizations per new chemotherapy cycle rather than patients as the units of analysis. To facilitate interpretability, hospitalizations were categorized based on the primary reason for admission: infectious, for example, pneumonia, bacteremia, or febrile neutropenia; hematologic, for example, anemia or thrombocytopenia; gastrointestinal, for example, emesis or diarrhea; cardiac, for example, heart failure; metabolic, for example, hyponatremia; or other. Primary cancer diagnoses were categorized as breast, lung, colorectal, and other, separating out each individual diagnosis that accounted for greater than 10% of the total cohort. Risk factor identification. Nested case control analysis. We collected additional data for a subset of hospitalized and non-hospitalized patients to build a model to identify independent predictors, that is, risk factors, for CRH. Through random selection, we identified 100 cases, patients who received chemotherapy and experienced a CRH, and 200 controls. Data on 33 demographic and clinical variables that we hypothesized might be associated with experiencing a CRH were gathered via retrospective chart review. For time-sensitive variables, data were collected on the day a chemotherapy regimen was initiated. Using bivariate analysis, we determined which covariates were associated with CRH. Those that demonstrated a significant association with CRH on bivariate analysis and those considered potentially significant based on previous clinical experience, 13 total covariates, were entered into a logistic regression model. Comorbidity score and performance status score were entered as categorical variables to facilitate interpretability. Aspartate transaminase was entered as a log-transformed variable because the primary data were not normally distributed. Age was not part of the baseline model because the comorbidity score included age as a component. Age and comorbidity score demonstrated a correlation of 0.6. However, as part of the sensitivity analysis, age was added to the model as a continuous predictor and separately as a categorical variable using groupings that mirrored the age component of the comorbidity score: less than 50, 50 to 59, 60 to 69, 70 to 79, and 80 plus. All primary data were entered into a Microsoft Excel file, Microsoft Corporation, Redmond, Washington, and subsequently converted to SAS files. Data merging, matching, and statistical analyses were conducted using SAS version 9.1, SAS Institute Incorporated, Cary, North Carolina. All p-values were two-sided. P less than 0.05 was considered statistically significant. The NSCC Institutional Review Board reviewed and approved the protocols for this study. Results. Among 2,068 cancer patients who started at least one new chemotherapy regimen at the NSCC between January 2003 and December 2006, we identified 826 total hospitalizations. Of these, 262, 26.3%, were classified as chemotherapy-related. The remaining were considered disease-related or unrelated to cancer or its associated therapy. There were 361 chemotherapy recipients, range 268 to 434, 17 total hospitalizations, range 2 to 30, and 5 CRHs, range 0 to 14, on average per month. Approximately 1.5% of chemotherapy recipients experienced a CRH each month, range 0% to 3.7%. The proportion hospitalized each month remained relatively stable throughout the 4-year study. Figure 1. The 262 CRHs occurred in 179 patients. Most chemotherapy recipients, 91.3%, experienced no CRHs. We were able to gather detailed information on 258, 98.5% CRHs. Comparing patients who did with those who did not experience a CRH, the mean age, 65.7 years versus 64.5 years, p equals 0.23, and percentage female, 59.8% versus 54.6%, p equals 0.18, were not significantly different. Table 1. Those who experienced a CRH were more likely to have received chemotherapy for adjuvant curative than for palliative purposes, 55.9% versus 38.9%, p less than 0.01. The proportion of chemotherapy recipients who experienced a CRH varied by cancer type. It was 14.2% for lymphoma, 11.9% for colorectal cancer, 7.2% for lung cancer, 6.4% for breast cancer, and 8.1% for other cancers. The CRH rate was higher when chemotherapy was given for adjuvant curative than for palliative purposes among lymphoma, 37% versus 10%, and colorectal cancer, 15% versus 8% patients, but not among breast cancer patients, 3% versus 7%. The characteristics and outcomes of CRH appear in Table 2. Gastrointestinal problems such as nausea, vomiting, or diarrhea were responsible for the largest fraction of CRHs, followed by infectious problems such as pneumonia or febrile neutropenia. The median length of stay for all CRHs was 5 days. Hospitalizations related to cardiac problems tended to be the shortest, whereas those related to infectious problems tended to be the longest. Mortality during chemotherapy was uncommon. Only 0.9% of all chemotherapy recipients experienced a CRH that ended in death. Among those patients who experienced at least one CRH, the in-hospital mortality rate was 7.4%. Patients admitted for infectious problems experienced the highest in-hospital mortality rate at 13.6%. Fatalities were more frequent among recipients of palliative than adjuvant curative chemotherapy, 10.1% versus 4.2%, p equals 0.07. Though on multivariate analysis this was only a borderline significant predictor. Odds ratio 2.8. 95% confidence interval, 0.9 to 8.4, p equals 0.07. The average time from chemotherapy to admission was shorter for fatal than for non-fatal admissions, 3.6 days versus 7.7 days, p less than 0.01. The distribution of CRHs by chemotherapy cycle number in which each hospitalization occurred appears in Figure 2. Approximately 2/3 of all CRHs occurred during the first 2 cycles of chemotherapy. Only 8% occurred after the 4th cycle of chemotherapy. It is not surprising that most CRHs occurred early on during the course of therapy because delayed cumulative adverse effects from chemotherapy are less common, and patients who experience serious adverse effects from chemotherapy usually do not continue to receive multiple cycles of the offending chemotherapy medication. We were not able to compare the risk for experiencing a CRH during each cycle because the total number of chemotherapy recipients at risk during each cycle was not known. Of the 100 cases and 200 controls randomly selected for the nested case control cohort analysis, chart abstraction was completed for 98 cases, 98%, and 173 controls, 86%. Patients for whom complete medical record data were unavailable were excluded from further analysis. Significant predictors of CRH on bivariate analysis included the mean comorbidity score, 3.9 for cases versus 3.0 for controls, p less than 0.01. A performance status score of 2 to 3 versus 0, 19.4